Ooh, got a weird little intro music with the sound and stuff and music. It's very creepy, but basically, I'm still using these stock graphics and stuff from the Restream platform because we've still not got our new fancy intro and stuff. So, apologies for those that are not enjoying our new countdown timers, but there are a few that prefer it not blaring in their ears, and so we're going to stick with it for now until I get my new one, which is this week, which is cool. So, welcome back. It's a new Monday. Also, our first show of the week, but last show of the month, 28th of Feb, makes it then the last of knee month. So I'm really delighted to be joined by Janet Thomas, who we're going to bring in a second, who's joining to talk about old knees. Now, when I approached Janet for this talk, she asked me for the distinction. It's classic, and getting to know Janet a bit over the years is central to her sense of humour. She clarified, do I mean to talk about old knees or talk about her own old knees? Of course, I was not saying, Janet, come and talk about your knees. She can if she liked, but that's not what I was suggesting. Janet is one of my sort of favourite go-to experts and particularly communicators of information with regards to treatment and rehab of the older person. Certainly, I've learned so much over the years about frailty, about management and rehab, and how we can apply that to an important patient set, and someone that bridges the gap between sort of clinical principles as well as then what that does to inform education and health policy. And so she's just absolutely brilliant thinker in this space. And I'm really pleased she can join me about all things old knees and meander around that topic a little bit for half an hour with me. Thank you so much for those that join me live. You do get stuck into the chat function across most platforms. It then comes through to me here, and I can integrate your comments and questions as you see fit. For those of you that are joining after the fact, please do leave your comments. We do see them, but then also if you want to get involved or recommend any future shows to this effect or otherwise, then do email info@physio-matters.com. The feedback does get back to us and is always much appreciated, regardless of what it is that you say about us, be that abuse and critique of my hair and accent through to kind words about the actual content. All welcome. We love it all. And so thank you for those that do get in touch with us. So without further ado, let me strip myself of this graphic thing that's going to otherwise get in the way and hopefully bring you Janet Thomas. Janet, can you hear me?
I can indeed. Thank you. And I was just about to say good morning, but it's not. It's good afternoon now, isn't it?
Afternoon now, yes, absolutely. So thanks so much for joining and talking about a subject matter that is familiar to some degree, but a bit more specific than usual because we're just honing in on one body part. But could we just start by, for those that don't know you and your background as to how you ended up in the specialty that you're in and what your day job typically entails?
Well, there you go. I've got 2 day jobs. My NHS day job is working in an assessment rehabilitation centre for older people. And if you don't know what that is, then the old term would be a day hospital. But it's nothing like a day hospital anymore in that people are not coming in for the whole day. It's more of an outpatient or community service for older adults. Yeah. And I've worked there for quite a number of years, I think is the easiest way of saying it. And then 2 days a week, I work in a university setting as a lecturer. So I do, they are completely separate jobs, but it's a bit of both worlds, really. But my passion has been for a very long time about rehab of older people. And I'm the current chair of IPTOP, which is the International Association of Physiotherapists Working with Older People.
Fantastic.
And that led on from roles in Agile in the UK as well.
Brilliant. And so I think as you just described some parts of that portfolio career, as is often the trendy way of putting it, but I've never considered that it would be very difficult for you to remove certain hats you wear, because from what I understand of you as a person, it's like pretty fundamental to your being that you're passionate about this stuff, and then these are just different avenues in which you pursue that goal. Is that right for me to suggest?
Absolutely, yes. If you'd said to me, I'm trying to think how long ago, 10 years ago, I suppose, that I'd be sitting here having set up a tweet chat, a physio talk that has been going for nearly 10 years now. Or that I'd be, working internationally, I would have laughed at you. But it's just how things develop, isn't it? A bit like today, you just have to think about what you say yes to and what you say no to. Because I did say to Jack that I was like, oh, I'm not so sure about live streaming, but go on, I'll give it a go.
Yes, absolutely. Well, you always came for that. So hats off to that, because you have there's been a number of different things over the years that we've sort of suggested, and it's been novel, and you've given us the opportunity, and we're really thankful for that. So here you are, giving it another whirl. What as well, we wouldn't disembody you from each individual role, but similarly, we wouldn't disembody the needs that we're about to discuss from the complex, interesting human that they're attached to. So, shall we start there then, as to what are the factors affecting older needs, shall we say, that make them maybe distinct from others, and also, of course, the important similarities.
Yeah, well, what you have to remember is I haven't seen anything younger than a 70, 80-year-old knee for a very long time.
Right.
I'm dredging I should have watched the young knee, shouldn't I, on Friday, but unfortunately I was at work.
Okay.
But yeah, I mean, my assessment that I do with older adults is part of a comprehensive geriatric assessment. So we are looking across the piece. And I think that's the important thing. Yes, I'm asking them about, well, every joint that they have. But the most common complaint of pain really is usually back, hip, or knees,
Right.
with quite a lot of them reporting knee pain. But I think the big thing is that they just seem to regard that as something that they should be expecting by the time they get to 80. And that is certainly a little bit of something I would like to discuss, because yes, it is, knee pain is more common as you get older. But there are things, of course, that you can do about it and address. So it's one part of a holistic overview. And of course, I'm not just looking at structure and function. I'm looking at, well, do you know, how they socialize, what hobbies and activities that they do, you know, all of that sort of thing that is very impacted by knee pain.
Of course. Yeah, no, that makes sense. I feel like I wonder, how do you find a way to balance, because I'm sure you will do, this sense that if a patient is thinking that knee pain, and quite significant knee pain, is nothing but inevitable and therefore is likely to disable them, so they wouldn't even raise it with you, which we definitely don't want them to feel. But then similarly, if they were too far the other way and they were just then even a mild bit of knee pain they were thinking was serious pathology, as if they were early 30s and it was disabling them in sport, there's a middle ground to be found. I'm sure some people find it themselves, but how do you make sure you communicate one thing without it getting snowballed into another?
Yeah, I think, as with everything, it's careful questioning. You're absolutely right. Every patient I see, as every physiotherapist says, is, do you have any pain? And often I get the answer, no. Right, okay. Do you have any aches or stiffness? And sometimes I even get a no to that.
Right.
But then as part of our assessment, we do the EQ5D, our quality of life, and it has a question about pain. And then they score themselves a 2 or a 3. So I go back to them and go, you told me earlier that you didn't have any pain. Oh, well, yes, I do. But it's been there for 20 years and I don't really think about it anymore. So it's teasing that out and going, right, okay, let's go back to where I wrote on my notes that you have no pain. Because that's it that often happens. They say, no, I don't have any pain, because they regard it as just, you know, them now. It's not new pain. I think they're thinking I'm asking
half
about
of the course
new, difficult, different. It's just actually, well, I've had that since, you know, I've been 60 and I'm now 80, and it's part of me rather than anything else. So then you have to sort of unpack that.
That's right. And that's it, unpacking it to understand as to, right, is that someone that, despite best efforts and comprehensive rehabilitation and questioning and not dissimilar assessments to this, that this is where I'm up to, that it's a pain that is livable, doesn't disable me in functional terms, etc. Or is this something that I've thought is inevitable and that there is nothing that can be done about it, that is based on assumption that actually nothing's ever been attempted or tried, or I've never really understood this pain better? Those are vastly different things, both diagnostically, let's say, or understanding the causal factors. But then also, when it comes to proposed solutions, you might have someone that has really never tried any of the even low-hanging fruit things that they can do to really improve both the pain and function.
Yeah, and I suspect that's what we get an awful lot of.
Right.
You know, I work with people who probably haven't been that active for quite a long time, which is why they've been referred to us, because they have frailty and falls and mobility issues. And some of that, I mean, it is chicken and egg. What comes first? Knee pain, frailty are very much interlinked. Knee pain is a predictor of frailty in the future. And I think a lot of the people I see, when I ask if they've seen a physiotherapist before or anything like that, no, they haven't. And commonly they won't even take even something as simple as paracetamol for knee pain. They just live with it because they don't like taking tablets. That's a typical 80-year-old for you. And again, it's unpicking that to go, well, actually, you're not masking anything by taking pain relief. And actually, it will help you, because then you can be more active, because you're not living with the degree of pain that you might have anyway.
Yeah, there's been reflections over the years on Physio Matters and elsewhere about how there is something there's of course some upsides to a very British stoicism over some of those things, but there's also one thing where I've ended up in some great debates with patients where it's like, but even if you were masking something, then it sounds worth masking, really. It's like, what is it for if not that? Now, they're worried because some of their peers sometimes, and this is me just reflecting on previous conversations, they're sometimes worried that, well, some of my peers are too far the other way and they just rattle when they walk and they're taking so much medicine for medicine's sake. And I'm worried about it snowballing. So it just feels like they don't think there's a good middle ground there. But if you can justify doing it as a means of aspiring function, especially if it's nested in rehab, which of course I'm now telling you stuff I've learned from you, really, that's one of the most useful things I've learned from you, is that you've said once you weave in some of those things that people wouldn't want to do in isolation, but weave them into a more robust rehab plan and improving some of the social circumstances and making them realize that activity increase doesn't need to be gym going, then that is where you can persuade them to integrate those things.
Yeah, absolutely. Absolutely. And of course, with older adults, we do need to think about polypharmacy. Taking 4 or more medications is a falls risk. And obviously, with the older you get, that you do have a risk of falls, particularly, like I say, I'm thinking about my client group who have been, obviously referred with falls.
Yeah.
And typically my patients can be on, we have electronic notes, and I scroll down the list from the GP, and I keep scrolling, and they're on multiple medications.
Sure.
And so that can be really quite confusing for them to go, well, what are the timings and what is it? And they just go, it's too complicated and I'm not going to bother. I'm taking so much other stuff as well. But yes, so it is having a conversation with them about the advantages. And I'm lucky, obviously, I work in a multidisciplinary team. I have doctors, nurses, OTs, physios wrapped around the patient that are all having the same conversation with them, really.
And then increasingly, that's a real area of progress, is that single hymn sheet, still evolving and progressing and stuff, but the MDT really pulling together in a broad way that there isn't as much of especially I find geriatrics to be a real shining light of dispelling the hierarchy, really improving that therapist with medicine type balance that is there, which is nice. The thing we said just off air before we went live, that we're going to be talking a fair bit about arthritis. So I think we get stuck into that then, because of course the most common pathology that should be and will be influencing our thinking there. What are the common things that your patients will say and assume and do around arthritis? How does it come up in conversations with you?
Yeah, well, I mean, they all just assume that they have, I don't know whether it's a Fife thing where I work or it's a Scottish thing where I work, despite my accent. Obviously, I am in Scotland. Yes. And they'll have a touch of arthritis.
Oh, right. Okay.
Oh, yes. Or something like
Language.
That. But I mean, it is common, over a quarter of people over the age of 70 will have some degree of arthritis. And so when you get to the people that I see who've been referred with issues that may be to do with their joints, it is incredibly common. And they come and only when you ask them really do they begin to sort of unpack the issues. Yes, they have pain and aching, but it's only when you ask them specific questions or when you're doing the assessment that they realize that they've actually lost range of movement. When I'm asking them how far can they bend their knees and I'm looking at it, they sort of go, oh, yeah, that's not as much as I could do, or I can't get down on the floor anymore. Can't bend to get down on the floor. And so they've not realized that they've got that degree of stiffness, but they have, because that's why they can't get down on the floor. And the other thing, of course, is creaky knees, crepitus. Could do a whole episode on creaky knees. And they get very concerned about the noises that their knees make. And yet, when I'm demonstrating things to, and my knees are creaking, it does allow me to say, see, don't need to worry about it. It's perfectly normal to have knees that creak.
I don't know if it's just me, but I'm losing Janet a little bit. So apologies if so. It might well be my connection issues. Sorry, Janet. I don't know if I've got you back now. Can you hear me?
Yeah. I can hear you perfectly clearly.
Yeah, sorry. I think it might well have been a local issue for me, so sorry to have interrupted there, but I just lost you for the last few seconds. But hopefully the audience didn't. But to follow on, I think from what you were saying is with crepitus. We did have a chat with Claire Robertson on our last Physio Matters podcast, mainly about patellofemoral pain, and you can imagine that crepitus, that obviously very prominent there across the ages. What the concern that means, and the way that people then make the association that crepitus is literally that you're just rubbing two pieces of sandpaper together, and avoidance of noise is going to be avoidance of further damage, is something that you end up having trying to do as much reassurance in that direction as you can.
Yes, because let's get on to it. I mean, we haven't used the phrases yet, wear and tear or bone on bone, have we? And that's certainly something that I think we need to explore as well, because they all, not all, no, actually that's not true. Obviously not all of them, but the vast majority do associate creaky knees and crepitus with damage. They've absolutely been told with the best intentions by a GP that it's wear and tear. And of course, there is normal aging in a joint, but I don't like wear and tear, as you might expect. And certainly some of them will have been told, issues about bone on bone, and they really are avoiding movement because of that. And then it's quite a tough ask to get them to start to move and to realize that movement isn't going to cause damage.
One of the first interactions I think we had years and years ago, Janet, independent of Physio Talk, to be honest, it was about wear and tear, where I felt that you were quite hot on that being quite nocivic inherently. And then I was sort of seeing it as being language that was appropriately couching and almost could be offered as reassurance. And we did differ on that. I have been persuaded since, partly because it's not anywhere near an accurate representation of what goes on, and that you've been vindicated there by the science as well, which you were closer to than me at the time. I mean, it wasn't a major thing between us, don't get me wrong, you might not even remember it, but it was just more that I remember thinking like, I think you'd noted that we were fairly hot on trying to move away from impingement. And you were saying it's not dissimilar, and I was sort of like, well, no, actually, wear and tear is not that nocivic. Whereas, is it that then patients that have either been told that or been suggested as such, they end up with this very narrow structural sense of their joints? Is that what you seem to see downstream?
Well, they end up with a fear and avoidance of movement. Right. Because not so much I suppose it is a combination, because it's very personal to each individual, isn't it? We can't have a broad brush approach. But I do think they start avoiding movement because they're concerned about the noise. They're concerned about, like I say, if you've been told it's wear and tear, then you stop moving because you're going to wear the joint out more.
Yeah.
Whereas, again, just before we came on air, I was saying I was watching some of the tweets come through from the San Diego Pain Summit last night, probably a little too late at night than I should have been, really. But anyway, that was by the by. And, just popped up at quite late last night was a presentation that was being given by, I'm going to get her name wrong, Tash Staunton from Australia.
Tasha Stanton, yeah.
And she travelled from Australia to go and deliver at San Diego. And what she put up was a slide saying it's not wear and tear, it's wear and repair. And I went, oh, that's what I've got to get in tomorrow, isn't it? Queuing over. Absolutely. And it's not. You are using your joint, but if you use it, then obviously the joint responds to what you're asking it to do. It's very much like bone health. If you sit and do nothing, your bones are going to get weaker.
Right.
If you sit and do nothing, then your knees are going to get weaker as well. We haven't even touched on strength yet. Most of my patients have sarcopenia, for example.
Yeah, sure. I mean, that's where I think the penias. Let's get into that, because how does we can kind of comprehend then be that chicken and egg with regards to, say, pain and underuse. Hard to know, really, isn't it? And we can understand then that challenge of understanding, and sometimes then it doesn't really matter as to which came first, because the solution is graded exposure to the things that it needs to improve those things. So sarcopenia being loss of muscle, but then also coupled with, no doubt, especially if there's a lack of weight bearing, then we would have some deleterious effect on bone health, bone density, and osteopenia and beyond. So when it comes to trying to motivate people to engage with a process of correcting for some of that, or preventing, depending on what phase they're in, or preventing deterioration, do you find yourself wanting to really front end that with appropriate education-based reassurance, akin to what we've just talked about, depending on what comes up in that assessment? Is that usually the starting point?
You've got to, because if I'm going to ask them to do more activity, and particularly we're going to ask them to do some strength training, as you say, graded, building it up, but we are addressing so many other issues as well as their painful knees. But actually, how we're going to address them isn't dissimilar with strength training, range of movements, functional activities. Then you have to address their fear and their avoidance of movement first. Otherwise, they're not going to do it. They're going to walk away saying, well, Janet's asked me to do that, and that's ridiculous because I know I can't do that because my joints are worn out. So you have to address that first. Yes, it's going to damage me further. What on earth has she asked me to do? And so it really is important. It's the same with any intervention, isn't it? If you don't have the adherence and motivation strategies in place, the education about why you're doing it there first, then you could be the best physio actually, you wouldn't be the best physio in the world if you didn't address that, would you? But you could be the best technical physio. You could ask them to do exactly the right thing for their knees, but they're not going to do it.
Yeah, I know what you mean. You could come up with some genius program that's not adhered to because you didn't then appropriately help them understand what to expect and also what it is it's trying to achieve. And that includes then, of course, assuring them as to the fact that these things might hurt a bit and this is why, and that, but similarly, not to grit your teeth and bear it as if it's agony. Trying to work out that balance between not oversensitizing.
It's the Goldilocks, really, isn't it? Not too much, not too little, and it's finding that right amount. So it's building up, usually, obviously, with like I say, frailer older adults from a lower level, but building it up quite appropriately. Yes, as I say, we do use weight training with 90-year-olds.
Yes,
and why wouldn't we?
Absolutely. We're trying to stimulate. Well, that's what we're trying to. That's the thing that's been a massive change in recent, I won't say years, but recent decades. There's some real progress made over recognizing that sometimes using weights as a means of stimulating physiological responses that bit quicker than, say, body weight could, because we're understanding the safety parameters on how robust patients are, including frail patients, right? That stimulating bioplasticity is definitely an area that I can see having really moved on, and obviously you've been pretty central to that, as have Agile and others that have really changed their tune on that in recent years to do that. Jim's asked because I'm not surprised he's watching this, because obviously with his interest in rheumatology and all things arthritis, but also is it mostly pain that's the issue? Because he posted this comment when you were saying about how someone will mention, I can't get to the floor anymore. Is it painless loss of function, like they develop stiffness and loss of range of motion, or is it primarily pain, or a bit of both when people tell you about that?
I would say it's both,
right,
because they will have pain, although they may refer to it more as an ongoing ache. really, rather than anything else. But when you ask about particular things, and obviously we do always ask about getting down to the floor and back up again with relation to falls, then they will say, I've not been down on the floor for years, and I couldn't get back up again. And it is to do with sometimes hip range of movement as well, and general strength loss. But quite often when you say as part of backward chaining them up off the floor, they're going to have to go on their knees and crawl. That's tough ask, because they haven't done it for so long.
That's when their eyes pop out
perfectly possible. Yes. And some of that is the range of movement that they're lacking. They struggle to do a squat, as in a deep squat, because they go too far down and they can't get back up again. So some of it is subtle changes in strength in different ranges. They can be functional in what you would call mid-range, I suppose, towards extension. But if you go too far into flexion, then they don't have the strength to get back out of there against body weight.
That's right. Yeah, you've got that almost that outer range quads that they've not been exposing themselves to. Even if I was just obviously narrowing it to one more clumsily, perhaps. But I think what I found, again, I think I'm pretty sure it was informed by your Therapy Live talk last year, was integrating what might have traditionally been considered backward chaining type breakdown exercises into functional rehabilitation, because they are really appropriately taxing. And so it was like, just, you wouldn't think about it, but just having someone go from one knee to standing, or from two knees to one, and as part of an exercise program within safe parameters, be that therapist guided or where safe on their own, just so that you're then training that. And the thing that really made a penny drop for me was that is such a biopsychosocial exercise. It was like, it was just something big, and then the social element being the assurance that they have over being able to participate more, even if the worst was to happen. Really, that helped me to realize just how profound that can be. Could you just tell us that and a few other clues around, say, functional rehab that you would recommend for solutions to these problems?
Yeah. Well, I mean, you have to start with the building block. So you have to make sure they've got accessible range of movement and enough strength. So I often say to people, we're going to start on the foundations first. We're going to, if they do have stiffness, work onto the range of movement. And often it is lacking full extension. And we haven't even spoken about any joint deformities yet. We haven't even got touched on valgus knees and the all of the different things that come across. So you start off with that, but then you absolutely work towards function. So an example, I don't know if it's a Fife thing or a Scottish thing or not, but we have an awful lot of people who go bowling, and I don't mean 10-pin, obviously. It's not brown green. It's not from my part of the world. It's flat green bowling. And they can't, because they can't bend down to pick up the bowls, or they can't lunge forwards to I was going to say bowl. I was trying to think of the right term, but it's bowl, isn't it?
Of course, yeah.
And so you have to work towards that with working towards, functional rehab. So we use quite a lot of really simple things: sit to stands, squats, step ups, lunges, going deeper into a lunge. Eventually, obviously, really going to the function. We will set up with bowls. Well, we have balls, I suppose, and skittles, really.
Sure.
It's
mimicking that action. It's a dynamic lunge, knee drops over front toe, and your torso has to follow through to keep your balance. It's a cracker, really.
Yeah. So it is. It is just. It's part of the. Like I say, right from the start, from the assessment, it's what hobbies and activities do you want to do and want to be able to achieve. With others, they haven't realised, in a sense, till you speak to them about it, that they can't get on the floor to play with their grandchildren, or in some cases, great grandchildren.
Gotcha.
And I did have one man that came in once with a picture of his grandson sitting on his back because they were playing at horses or whatever. And I pointed out that meant he'd got down to the floor and had his knees past 90 degrees. Well, didn't quite phrase it like that. And he went, "Oh yeah, it's very true. Couldn't have done that before." Really important to the social aspects of improving knee function.
Absolutely, and also just those moments where it takes for a functional position to help someone realize their actual capacity, be that having increased from work or from them understanding their own abilities, that they might then realize that, oh, I couldn't do that, but you
Yeah.
actually would if you were exposed to it in day-to-day life. And so that negotiation, and sometimes being able to hold a mirror up to people, with their best interests at heart is an interesting one for sure. Really interesting question coming from Sally Robertson, and then we'll finish on this. But what's your opinion on total knee replacements or partial knee replacement patients kneeling?
Oh, we get this all the time. Because obviously, as part of our falls work, we're doing backward chaining, and I've had a
Yes.
knee replacement, and I've been told I can't kneel. Well, obviously, you do have to go by what the consultant has told you, but most people are being told that they can't kneel for the first 3 months, usually, and because of just healing of the soft tissues, obviously, more than anything else. But in their head, they can't ever kneel. And it's quite a big barrier we have to get over. So absolutely, if they're far enough past their knee replacement being put in, of course, a lot of people I see, I'm not seeing them immediately post-op. I'm seeing them 5-10 years down the line. Then absolutely they can kneel. The issue with the patients that I see is they probably don't have enough range of movement to be able to properly kneel, because they just didn't quite gain enough range of movement with their rehab immediately after having their total knee replacement. They got enough to be able to function, but now the scar's healed and everything like that, and it's fine. So I don't have an issue with them kneeling unless they've been told for some weird and specific reason not to. But mostly the restrictions are immediately post-op rather than down the line.
And one of the things that's good about, I mentioned about how the MDT being less and less hierarchical in geriatric medicine and stuff is one of the things that's been useful is surgeons have moved towards understanding some of the downstream effects of that language, as well as them, when challenged, why would you not want them to do so? The main reasons they've said is, like you say, about how there being sort of chafe friction on scar sites, etc. As well as then people, if they've not got north of 100 degrees, then they're going to end up in a really high point kneeling position that's going to be uncomfortable anyway. So then people say it's too painful to.
Yes.
So once you unpick the why, then there is no hard and fast. Absolutely don't. So that's a really interesting one, and I think certainly has moved. Progress has been made with surgeons, as well as then I think it's been good therapy at its best, really interprofessionally, isn't it? To say, well, why not?
Why not?
It's like a bit like the hip precautions, didn't we? With the
yes.
It's like, well, let's just go into them again and think.
Yes. I mean, I can remember years ago as a student in Wrightington Hospital. There we go, many years ago.
From me,
yeah, exactly. They used to get people out of bed almost with the wedge still in position in abduction as a sort of wanna. That was 30 odd, nearly 40 years ago. It was a long time ago.
Yeah.
Whereas now, I mean, you wouldn't even contemplate that, would you? You'd get them up the same day. And this is, of course, after they've been in bed for. So it's the same with knees. It's moved on.
Isn't it funny though? Those things just they loom large for so long, don't they? Because it's just reminded me about the whole I've been told I should never cross my legs, and you're just like, we just had you hiking up a mountain. You're lifting weights. Your great grandkids are on your shoulders. Yet crossing your ankles when you sat in the waiting rooms, no. It's just like, why? And it's usually that some surgeons' words have loomed large, or their precautions that they had for a few weeks have then carried over.
It's the precautions for that immediate post-op that. Yeah. Because that was given to them at the time, and it was in the booklet, and it probably did say for 3 months or something.
But they've missed that bit.
They've missed that bit, and they're really focused on that. Because of course, a knee replacement is a great thing.
Absolutely.
Again, we haven't even touched on knee replacements, which I have an awful lot of patients that when I look at their knees, I go, "Oh, right, okay, what have you had done?" And they can be great.
Absolutely.
If used appropriately, obviously. There's an awful lot of rehab could go down first before you go to a knee replacement, which maybe not happens.
But it's a cracking intervention. I think that sometimes that there has been a funny one because physios are positioned to, we're always aspiring to keep people from the knife. And it's not a bad, it's a smart ambition in many ways. But then you don't want to do that to the detriment of creating a bit of a bogeyman over a knee replacement when it's a really successful intervention, and that some people have done, torturing themselves to avoid what would be a really helpful surgery for them. So that's a funny balance that I've noticed in advanced practice. Even in my own experiences, I think I've gone too far that way and have created a bit of a monster that I needn't to done as a means of trying to motivate rehab, which I think, on balance, I regret a bit.
It's because we haven't even really spoken about what age do we talk about when we're talking about old knees. Some of the research starts it at 45. Really? Some of it at 55, and shall we just say that would make my knees most distinctly old. But if you're talking about later on, then obviously the length of a knee replacement is going to be absolutely appropriate. And I've seen patients have had the same knee in for 20-30 years, certainly. So, and that's with a knee replacement that was put in 30 years ago.
Well, that's the shelf life of them are improving. Our knowledge and understanding of that, we did err on the side of caution over that when they didn't understand the sort of mechanical properties of those sorts of things, and also the mechanical properties of the implants improving. So lots that have been learnt there, and a lot of it in a really reassuring direction for all of us in terms of those interventions. As you've mentioned there, you've mentioned about 5 things we haven't talked about, and so maybe one for another day. If this live stream hasn't been too painful, Janet, then maybe we'll do it again. But it has flown by, and we're in overtime. So I will let you go. But thank you so much for joining me today. I really appreciate it. Where do people find you on Twitter and any other resources you want to point them towards?
Yep, absolutely. I'm on Twitter at Janet Thomas 47. Sadly, not my age. If only it was. But obviously, I'm also on Twitter at Physio Talk. I'm also on Twitter at Top Physio. Dearie me, I have quite a few Twitter accounts. I'll stop there. I do have
all. Find Janet on one or all of those.
Yes, on all of those. Yeah, absolutely. But no. So yeah, you can contact me any way you wish.
That's super. No, thanks so much. Really appreciate it, and really appreciate you being a voice in this space for all of us, because it's useful for us to have those specialist understandings of how these things do. There's a lot that we can carry over from broad and general conversations about needs, but as you've said, joining the dots to the social aspects and the functional aspects that affect people later in life is something that we need to keep in mind. So really do appreciate your work today and beyond. So thanks a lot, and we'll speak soon, no doubt, Janet.
No, thank you very much for inviting me. It's been a fun way to spend my lunchtime.
No, nice one. I'm glad. Thanks a lot. I'll speak to you soon.
Okay, thank you.
All right, bye-bye. So I'm just gonna wrap up there, because I'm sorry we're into overtime. I've got a show on Friday. We're doing Mondays and Fridays now, and really looking forward to getting into what will be shoulder month, which is for March, and so we're going to get stuck into that, and I'll be announcing some graphics for what's going to be entailed there. We've got some interesting news as well with regards to those that have spotted that Therapy Live is now tickets on sale for 2022's Therapy Live, in which we're also trying to get people together in person and having lots of options there for hybrid events. Physio Matters has some big news as well as it approaches its landmark 100th consecutive month, which occurs in April. And so do keep your eye out if you're a Physio Matters member on your portal, but also then on newsletters as well. If you are on our mailing list, then please keep an eye out for there, because there's some exciting news to come for both Therapy Live and Physio Matters. But for now, I'm going to bid you farewell, and you've got a few more. Maybe this might even be the last show. I've been saying this for a while, until we have the new fancy intros and outros. But in the meantime, what I've been doing is I've been awkwardly waving until the stream ends. So